All right. Who knows people with rheumatoid arthritis here? Now you have to distinguish between rheumatoid and osteoarthritis. Osteoarthritis is different. Osteoarthritis affects everybody, especially nurses. So anyone who works on their feet like we do, we use our hands, our fingers a lot. We're always on our feet. Eventually, we're going to have osteoarthritis. So not only our large joints, but including our spine as well, right? So that's something we have to look forward to. So my sister is retiring. She just retired. Actually, she retired last year, but she still does extra work, extra money for in addition to her 401k and her social security. So she makes a few, maybe under $40,000 a year. You're still allowed to make that money. But because she worked too long at the bedside, so she's now using a cane even after knee replacements and hip replacements because of osteoarthritis, all thanks to nursing. So she can't really enjoy retirement as much. I mean, every time we go out, she slows us down. Of course, I don't tell her that, because I'm always the one holding her. But I was always thinking, oh, there's so much I could have done now. Okay, but of course, I love my sister. Um, but that's something you have to think about. Okay, so if you want to enjoy, don't wait till retirement, because that's what we're gonna look like by retirement. The things we do, we're gonna end up the cane, very slow mobility. Okay, so it's not what you picture all the time. All right. Okay, so what is rheumatoid arthritis? This is autoimmune. Usually runs in the family, so there's a genetic component to it. Females are affected 3 times more than, well, you have your textbook, yeah? We're on page 1078. So far more women are affected compared to men. Age affected doesn't really distinguish. Okay, so you can be affected in your third year. So the usual affected age range is between the third to the sixth decade of life. So between 30 and 60 years old. That's usually the onset of rheumatoid arthritis is. So contrary to popular belief that, oh, that's an old person's disease. No. Okay. Osteoarthritis is an old person's disease. Okay, because that's from wear and tear. This one is autoimmune. So therefore, this doesn't wait until you're old. Okay, whether you're healthy or not, this can affect women more than men, again, between 30 and 60 years of age. So this is autoimmune. What happens here is your own body, your antibodies attack and destroy your joints. And the pattern here, we'll look at signs and symptoms. The pattern usually is symmetrical, meaning if it affects your, let's say your thumb, it would be both thumbs. Okay? If it affects your knee, it'll be both knees. Okay? It's always symmetrical. And let's see how debilitating this disease can be. So long story short, if you read the pathophysiology, this is again caused by, well, because it's autoimmune, we don't know exactly what causes it, but we do know what happens. So when you have your autoantibodies destroying your joints, so therefore you lose cartilage in your joints. So here, the RAs, the synovium breaks down collagen, there's edema, there's swelling, there's fluid buildup there, and then the cartilage and the bone is destroyed. So now your joints, especially your fine motor joints, unlike osteoarthritis, which usually affects large joints like your hips, knees, joints, shoulders, this one affects your fingers, your fingers and your toes, although it can also affect your elbows and all other joints, but mostly your hands are affected here. It can also affect different organs of your body, but most cases, the manifestations are in the hands and the fingers. Now, what separates us from all other primates, from all other animals? What makes us unique besides our thinking? Our fingers, correct? Okay, so our fingers allow us to do so much more compared to lions, ants, and everything, all other organisms, right? It's really our fingers. So once you lose the mobility of your fingers because of these formations here, you have Panus formation, which will be, you'd have some nodes, and you lose mobility in these fine motor joints, and they also get deformed. Okay, I'll show you a picture shortly. And together with the inflammatory process is it, like I said earlier, it can affect also other organs of the body. It can affect your vascular system as well. Here you'll have problems with atherosclerosis as well. So you can have heart disease at the same time when you have rheumatoid arthritis. But the most common debilitating aspect is the movement. So how can we work as a nurse? We need our hands and our fingers a lot. That's really majority of what we do, correct? Of course, you can do other aspects. So let's say you have RA already and you have deformed hands, you can still do teaching, correct? The good thing about nursing, there's so many things you can do. You don't have to be at the bedside. You can be telehealth nursing, for instance, or you can be a teacher like me, right? I don't need my fingers, I don't think, right? Do I? I do. I need to pick my nose, okay? And no, do the paperwork in the bathroom, can't have Yaya cleaning after me, right? When I do number 2. So I do need it. But the classic manifestation is systemic inflammation here, specifically in the joints, and then of course it will also affect the rest of the body. To make a diagnosis of RA, it's not really that simple because the tests mentioned here, specifically the rheumatoid factor, for instance, or the ANA antibody, the ESR, CRP elevation. The problem with these tests is, yes, they're present in rheumatoid arthritis, but they're not exclusively seen in rheumatoid arthritis. They're also seen in other conditions. So here, the diagnosis is made by the doctor based on these tests plus the patient's clinical symptoms. Are we clear? So it's not always easy, therefore, early in the disease, because early in the disease, this resembles osteoarthritis. Okay, and then if they look at these testing and then also the patient's clinical symptoms, what are you feeling, right? And then they arrive at the diagnosis. But look at the next paragraph. Initial manifestations, like I said, is not really exclusively seen in RA. This can be mistaken for other diseases, specifically lupus. You've heard of lupus? Okay, so lupus shares all the manifestations in RA, meaning all these manifestations mentioned here are present in lupus. So that's why it's very hard to distinguish between, especially early in the disease. In the advanced stage of RA and lupus, they're very easy to tell apart. But earlier, which is crucial in diagnosis and therefore treatment, you may be misdiagnosed. Therefore, because it's a misdiagnosis, then you're treated for a different disorder. That's usually what happens, okay? Even for some endocrinologists, because you're, of course, the specialist here is an endocrinologist, okay? That's who you'll see. Same thing as thyroid problems. So this is the same specialist, okay, that will treat RA and lupus. So here are the joint involvements. So there's some bony changes, and then later you'll have these deformities here. Ulnar deviation. Ulnar deviation means now your hands are now shaped, instead of my hands shaped like this, it will be like this now. The wrist joint is now deformed and my hands will look like this. And then when we have swan neck deformity, you know what a swan neck is, right? It's now like this. Okay, let me show you a swan neck picture. Is there a picture in your book? No. Okay. Okay, so here's wonderful pictures of swan neck deformities. So if your fingers of one or both hands, usually both hands, are now like this, how can you button your shirt? How can you close your zipper? How can you roll toilet paper and wipe after yourself? How can you drive? You understand? Okay, so this is the debilitating form, especially if the patient chooses not to be treated. Now, again, the misconception is rheumatoid arthritis, some people, or most people, I should say, mistake it for osteoarthritis. Well, it affects all joints, but again, what distinguishes us really is from other animals. Again, the most important part of our body, especially as nurses, are our hands. Okay, that's literally how we work, how we do our job, right? We can't do ADLs without using your hands, can you? Even if you're, let's say, oh, you can still play football, okay? You can still play, or some people call it soccer, right? But you need your hands for everything else, correct? So you literally become disabled here. Okay, you cannot do your job. Some may say, oh, then early disability for me. Yeah, but you can enjoy life with these hands. Okay, they can be surgically. This is ulnar deviation. See this picture here. That's the ulnar deviation, and then if you have both ulnar deviation plus the swan neck deformities, okay, so that will be debilitating. Okay, you cannot function. I have my I have an aunt in she moved. She used to be in Jersey. She moved to North Carolina. She has these hands now, but she's a very proud woman. She's over 80 years old. She still drives. Okay, she refuses to live with her children. Okay, I can live by myself. Okay, although she lives with close to her oldest son, who's an ophthalmologist. It's her favorite son. Anyway, yeah, she's living independently. Okay, but of course she downsized. She's in a small townhouse now. So that's what you have to look forward to, okay, with rheumatoid arthritis. As I said, this is a systemic disease. So not only are your fingers, but all other joints of your body and some other organs also will be affected. And usually it comes with other diseases as well. So most people with RA also have fatigue, weight loss, lymph node enlargement, and Raynaud's phenomenon. Have you heard of Raynaud's? Okay, so what is Raynaud's phenomenon? This is a painful stress-induced vasospasms of the hands. When you have Raynaud's, not only cold, but also stress. So I had two students before and they were sitting right next to each other. They were good friends. And then they discovered that they both have Raynaud's phenomenon. Their hands literally turn blue in the winter, very painful, and also during examinations, because it's stress induced. So stress and cold weather causes the symptoms. Although it subsides, eventually there's really no treatment for it. Okay, just like, well, RA, we have immunosuppressants. We'll discuss the treatment shortly. All right. Let's go now to the, like I said earlier, for the diagnostic testing, they're not specifically, meaning we don't have any test that exclusively helps diagnose RA. Okay, it's a combination of the blood tests as well as the clinical symptoms of the patient. Management, it's all medications and of course exercises, physical therapy. So let's start with the medications. The most common DMARD and the cheapest is methotrexate. DMARD is disease modifying anti-rheumatic drugs. Again, the cheapest is methotrexate. Problem with methotrexate is, remember, these women are mostly women, right? So women age what? 30 to 60. So are they still, is there a population where they're childbearing? Yes, methotrexate is a teratogenic drug. So be careful while on it. So since it can cross the placenta, so what should you do while taking this drug? And you're between 30, 40 maybe. Okay, birth control. So advanced planning, okay, is necessary. Now, the more expensive options here, because we'll look at the side effects of methotrexate. So a few are mentioned here. So this causes anemia. So you have to monitor CBC for this drug. It can also drop not just your red blood cells, it can also drop your WBC. So meaning this can cause neutropenia as well, meaning makes you susceptible for infections or to infections. And here are other options. Other DMARDs are leflunomide, sulfasalazine, or hydroxychloroquine. Yes. The more expensive options are the ones you see on TV. You've heard of an example of TNF, this is referring to tumor necrosis factor inhibitors. You've heard of Humira on TV, Humira, adalimumab. Okay, that's a TNF-A drug, very expensive. Then we have anti-interleukins as well, meaning interleukin inhibitors. Now they're very specific, interleukin-1 and interleukin-6 inhibitors. They're listed on the table. Okay, we'll get to the table shortly. For pain management, because these drugs here only serve to, like I said, there's really no cure for RA because it's autoimmune. There is no cure. What we're aiming for here is to put you in remission, meaning reduce your symptoms, because this is inflammatory, correct? Meaning it's caused by joint inflammation, correct? So you have to take drugs to suppress your immune system. And unlike steroids, these drugs are better, methotrexate and these cell-specific, more expensive DMARDs, because they're not going to suppress the entire immune system, plus none of the broad side effects of steroids. So these drugs are still preferred over steroid therapy. Okay, we'll discuss steroid therapy and its consequences next semester. For the joint pain, here are the options. Nothing really works for joint pain in both osteoarthritis and rheumatoid arthritis except NSAIDs. Okay, NSAIDs are the preferred effective pain management option for this type of chronic disease. And there are different types of NSAIDs, so we'll talk more about NSAIDs next semester. The consequences of NSAIDs, including peptic ulcer disease, although we will mention these again when we get to the pain chapter, chapter 12. I think that's in 2 weeks. Here's examples: ibuprofen, naproxen, and then we have lesser side effects compared to these two are the COX-2 inhibitors, celecoxib, for instance, because unlike ibuprofen and naproxen, which are notorious for causing uh, kidney damage, GI ulceration, as well as heart disease. Now, the heart disease here is affects only if you have an existing cardiac disease. Okay? If you're otherwise healthy and you're taking NSAIDs, usually you don't have any known cardiac events. But however, if the patient has a cardiac history and they take these NSAIDs, then they have more cardiovascular events. What I mean is acute coronary syndromes, chest pain episode, okay, or heart attacks. Right? Mostly NSAIDs. And of course, non-pharmacologic interventions are relaxation techniques, heat and cold therapy, especially warm showers, for instance. We don't recommend warm baths because they might not be able to get up from the bathtub. Okay, so we prefer showers compared to soaking in the tub. Does that make sense? Because the joints are really painful, so it's quite dangerous for them to be in a tub. I mean, taking a bath. Okay, let's go to okay, let's talk about steroids here in this paragraph. Now, steroids are only used when the patient has unremitting inflammation, bridging basically. So what this means is you've seen the concept of a bolus earlier, yeah? You did your simulation for DKA. Okay, so you gave a higher one-time dose of insulin, yeah? And you gave it IV push. So same idea here. So when you want to get the treatment going, the patient may be put on systemic steroids for a short while until the DMARDs start working. Does that make sense? Okay, so it's a bridge, meaning you want to facilitate the anti-inflammatory treatment, meaning the immunosuppression treatment, get the symptoms improved, okay, or eliminate the symptoms fast by using steroids, because again, steroids inhibit everything. Unlike methotrexate, adalimumab, for instance, which are cell-specific, only targets those parts of the immune system cells that are responsible for the symptoms of RA, responsible for joint inflammation and swelling. We can use steroids at one time, all right? And then, of course, we taper it off and then just leave you with methotrexate and any of the other DMARDs. Does that make sense? And you can use these ointments. They're diclofenac. I use diclofenac because I have osteoarthritis. That's a topical NSAID. Diclofenac is an NSAID, but it's has lesser side effects because it's only on the skin. It's topical, okay? So I don't take it orally, so it's not absorbed systemically. And here, some supportive treatment will be, imagine you're 30 years old and you have the swan neck deformity. Are you still out partying with your friends? Attending baby showers? Baby showers and you look like that. So what do you tend to do? Stay home. And how does that look? You're on Facebook, okay? That is if you can still scroll on your phone with those fingers, right? Okay, and then you look at, pictures of your friends having a party, getting drunk, and here you are getting drunk on your NSAIDs. Okay, so that causes depression, yeah? So now these are now supportive treatment. Okay, so if you have depression, insomnia because of your condition, then here are some treatments, okay? But that has nothing to do with the joints. Obesity is a concern. So if you have an obese patient with rheumatoid arthritis, that makes things even more difficult. Yeah. Okay. So mobility is even more concerned here. Okay, imagine obese patient with the ulnar deviation and the swan neck deformities. Yeah, extremely difficult. All right. So mobility is a big concern here. So we have mobility and pain management together, right? And then plus the treatment we know causes immunosuppression. So these patients are at risk for infections. And we haven't even started with the drug side effects yet. So we have an entire table for that. Let's get now straight to the table 34-2. Please read nursing care, especially about what to teach the patient, especially promoting mobility. Right? Exercises, what type of exercises, when to do them. Okay, so here's your teaching. Let's go to the table now for the drugs. Let's look at the link. Okay. Table 34-2. Chapter is this? So here are your tables, page 1072. Now, it's not necessarily in the rheumatoid arthritis chapter because these same medications are also used in lupus. It's also used in systemic sclerosis, meaning they're used for all connective tissue disorders, which rheumatoid arthritis is one of them. Do you understand? Again, this table is not necessarily under the rheumatoid arthritis section because it's used in other connective tissue disorders, meaning rheumatoid arthritis is just one example of a connective tissue disorder. Okay, this happens to be autoimmune, but meaning these are not exclusively used for rheumatoid arthritis, meaning later next semester, when we talk about lupus, you'll see the same drugs again. All right, because same treatment is used. So we know about NSAIDs. So you got aspirin, and then your ibuprofen, and then the topical diclofenac, celecoxib, COX-2 inhibitors. Here are your DMARDs now. So most common again is the methotrexate. Here, hydroxychloroquine, remember this in COVID? This was very popular. People were using this, right? This is an anti-malarial drug. And here are your nursing responsibilities. Okay. Not mentioned here is hydroxychloroquine is also known to cause dysrhythmias. So not just photosensitivity, but also cardiac dysrhythmias. Here, sulfasalazine was mentioned in the paragraph earlier. Now, sulfasalazine, for instance, this is also used in Crohn's disease. Does that make sense? Okay. So meaning it's not exclusively for rheumatoid arthritis patients. It's also for other autoimmune disorders. You follow? Here's methotrexate. So you need to know about methotrexate since it's the cheapest and most commonly used. Yes. Azathioprine, or I think this is Imuran. Okay, Imuran is also used in multiple sclerosis. Okay, so many used here in RA, used in lupus, used in multiple sclerosis. Okay. Same thing for cyclophosphamide and cyclosporin. So we'll use these drugs again, even in organ transplant patients, because what are these drugs doing again? Suppressing your immune system. Now, the same immune system cells are responsible for organ rejection, meaning transplant rejection, and also for RA symptoms. You follow? All right. So here are the more expensive options. You've got TNF inhibitors, adalimumab. This is Humira. Now, what do you hear in the commercial? What do they always say? Before starting Humira, tell your doctor if you had TB or are prone to getting TB. Yeah? Why do they say that? So we just concluded TB for exam 1. Who are at risk for TB? Is it everybody? No. So who are the susceptible hosts for TB? Immunosuppressant patients. So therefore, what do these drugs do? Cause immunosuppression, cause you to get TB. Does that make sense? All right. So here, before starting Humira, which is adalimumab, tell your doctor if you have TB or are prone to TB. So there's some use to watching TB. You learn things in the commercial. Abatacept, which ones are on the exam? Sad to say, I will have to test all of them because all are used in the market. Okay, let's talk briefly about anakinra. Now, anakinra is an IL-1 or interleukin-1 receptor blocker. Here, used in moderate to severe RA, meaning if they have no success from the others, from adalimumab, from methotrexate, this is an option for those patients. Does that make sense? Okay, so they can use anakinra. Now, what do they have in common? So look at on the third column under nursing responsibility or patient teaching. These are subcutaneous injections. Here, rituximab, abatacept, adalimumab, these are all subcutaneous injections. So who's giving them? Patients. The patients are self-injecting these drugs. So therefore, what is part of your teaching? How to administer. Here, also storage. Okay? Medication must be stored in the refrigerator. Right? So these are details I can put on your exam. And for steroids, so you have way so much side effects from steroids. Right? Hypoglycemia, hypertension. Hirsutism is excessive hair. Okay, hair where you don't want hair. You want hair around your nipples. You want hair on your chin. You want to look like a man. Okay, so that's what hirsutism is. Again, who are affected here for RA? Females, 30 to 60. They look like that. And that's it for the drugs. Any questions? Okay, let's take a break. Come back at 2:50.